Well, good afternoon for this afternoon's Data Science Roundtable, presented by the Surgical Data Science Collective. I'm absolutely delighted to welcome Dr. Jacob Young, who will be presenting this afternoon with support from Braxton Morrison. Thank you both. Let me take a moment to introduce Dr. Young. Dr. Jacob Young is a neurosurgeon who cares for patients with brain tumours, including low and high-grade gliomas, meningiomas, and brain metastases, cancer that has spread to the brain. He specialises in brain mapping techniques that identify areas important for motor, language, and sensory functions, enabling surgeons to minimise the impact on those areas during surgery to remove a tumour. His clinical research explores how to optimize functional outcomes and minimize complications after surgery for intrinsic brain tumors. Dr. Young's translational research interests include first-in-human, early-phase clinical trials of new immunotherapies and innovative ways to deliver drugs to treat cancerous brain tumors. In his lab, he focuses on understanding the microenvironment of glioma and how it contributes to intratumoral heterogeneity, differences between cancer cells within the same tumor, treatment resistance, and cancer evolution at the time of progression. Working with numerous collaborators, his ultimate goal is to design treatment strategies that improve outcomes for patients with brain tumors. His glioblastoma research has been recognized at the institutional, regional, and national levels. During his postdoctoral training, he was awarded the Chan Zuckerberg BioHub Physician Scientist Fellowship, the Andrew J. Lockhart Focus Ultrasound and Immuno-Oncology Fellowship, and the American Society of Clinical Oncology Young Investigator Award. Dr. Young earned his medical degree from the University of Chicago Pritzker School of Medicine, where he was elected to the Alpha Omega Alpha Honor Medical Society. He completed a residency in neurosurgery and a postdoctoral fellowship in tumor immunology at UCSF, where he received an exceptional physician award during his training. He was recognized with the Crayons Award for Excellence in Patient Care at the Zuckerberg San Francisco General Hospital and the Howard Nafziger Award for Outstanding Clinical Service from the Department of Neurological Surgery. Dr. Young, we're absolutely thrilled to have you here today, and we're looking forward to this presentation. Thank you, and over to you.
Well, thank you, Rachel, for the very flattering introduction. I want to just start by commenting on the incredible work that Braxton Morrison did to help put together this presentation. As you may have picked up, not a lot of my prior background research has been in operative video and artificial intelligence, and I've been very fortunate to work with trainees and young members of the healthcare team to get involved in some of this space. So I'm hoping that this is a really interactive and engaging discussion, and I'd like for people to interrupt and ask questions. I think that would be much more enjoyable for everybody. So without further ado, the outline for today, I want to talk a bit about the history and current state of neurosurgery residency training. How do we actually train surgeons? I want to think about the challenges that are facing resident education, talk about how good we are in the current state of training residents, and really end the discussion, hopefully in an engaging way, with how can we do better. And to go and think back about the history of training residents, back in the days of Halstead, residents truly lived in the hospital, and so they were residents for their training period, and there were no such thing as work hour restrictions or time that was basically allotted for anything other than your professional career. And that model in that era has come to an end. And so we find ourselves in an environment now where, even though neurosurgery is the longest residency training program of any specialty, we have fewer and fewer opportunities to teach trainees how to perform these procedures. So to just kind of set the stage, when neurosurgery first became an independent residency away from general surgery, programs were 5 years long. There would be a 1-year internship followed by 4 years of dedicated neurosurgery training. Now, all training programs are required to be 7 years, and that's really because sub-specialization has exploded, and the thought is that more time is needed to understand more specialized and increasingly divergent areas within neurosurgery. A lot of programs will have 1 to 2 research years, so not all of the 7 years are clinical in nature. And even with this extended training program and dedicated research time, post-graduation fellowships are becoming more and more commonplace, and we'll talk about whether that's necessarily a good thing or not. Um, this is just an example. I pulled this from the internet from the University of Cincinnati, but to give you a sense for the progression in the years, the intern year is considered the PGY 1 year, the PGY 7 year is often in many programs a chief residency or potentially even an enfolded fellowship opportunity to do advanced specialized training. And you can see that lots of time is spent across the intensive care service, the endovascular service. There's probably spine dedicated time, there's functional dedicated time. And so even with this very long training path, not all of the time is in the operating room. More and more time is being spent doing other sorts of tasks, and we have to improve how we get educational opportunities during our training. The residency duty hours have really played a big role in this. In 2002, and it was like activated and it was enacted in 2003 that 80 hours were going to be the maximum amount of time that residents could work over a 4-week period, excuse me. And they changed the amount of time that interns were allowed to work. You were only allowed to work 24 hours consecutively with 4 hours of handoff and educational time. So 28-hour shifts became the longest shift that could be worked for an intern. Um, there's also been other changes that have decreased resident autonomy. There's been more demands for clinical efficiency from the hospital. There's been concerns over patient safety, including the practice of running 2 rooms at the same time for an attending, which means that there's less resident autonomy. And there's been quite a few publications that have looked at the impact of some of these policy changes on overlapping surgeries and resident autonomy and how that's changing preparedness for our graduates in neurosurgery. And I think, this slide is a little bit for fun, but the journey is long because the stakes are high. Whether we're taking out a tumor in the CP angle or doing a motor mapping case for a glioma near the corticospinal tract or operating on a metastatic spine tumor that's causing cord compression or using a stent retriever to remove a stroke or potentially removing a subdural hematoma that is in the setting of a traumatic brain injury. These are all potentially life or death situations for patients. And so the stakes are quite high. And that's why the training path is long and rigorous. Um, and even outside of neurosurgery, there's been lots of publications that have shown that there's a decrease in resident-driven cases. This shows over time, orthopedics, ear, nose, and throat surgery, urology. These are resident-led cases at the VA, which tends to be an area where there's more autonomy and training programs, and the slope is clearly down over time. So there are fewer opportunities, which means we need to extract more educational potential from each experience in residency. And that's what I want to spend a bit of time talking about today. I do want to have a short little video that I hope is somewhat comedic, but there's an increase in fellowships after training, and some people are even doing multiple fellowships. So 1, 2, 3 years of extended training after you complete a residency. Now it's over 50%. This is back in 2016. I bet the updated numbers are even more for fellowships. And this
the new med student.
I hope
Why?
the audio is coming across.
Excuse me? Why should I let you into my OR? Well, I just did general surgery. General surgery. So you were on vacation and now you're ready for some real work. Yes. Let me introduce you to the team. This is Tim. Tim is our intern. He doesn't talk. He can't talk? Oh, he can talk. He hasn't earned the privilege yet. Over here we have Joey. He's a 4th year. He's incredibly mean and already has an ego of a neurosurgeon twice his age. And back there in the corner is Jonathan. He's our senior resident. He has a wife and, oh, boss. Again? Well, anyway, that's the team. It really does take a village. Yeah, I can tell. No, I mean that literally. All my residents live in a compound in the hospital basement. Joey hasn't been outside in months, and I love it.
Obviously, that's meant to be funny, but I think we have to do a serious introspection of our specialty if the culture of the field doesn't allow for people to finish training until their mid 40s and they aren't having a quality of life that allows for them to have successful relationships or enjoy anything outside of work. And so I think we need to be concerned that we can't complete training in 7 years and get people ready to pursue their own independent practices. Um, and as a junior faculty member myself, I think I want to make the point that significant growth still takes place after training is completed. I have felt my own surgical expertise has increased dramatically as I started my career, and there's been paper after paper in fields beyond neurosurgery and general surgery and surgical oncology that have shown that there's a really significant relationship between the volume of a surgeon and their complication rates or their patient outcomes. And so when you're starting your career, I think you're at one of your most vulnerable positions as a surgical attending. You have no longer the luxury of counting on more experienced attendings to help you with cases, but you are not considered a trainee and are supposed to be fully functioning as an independent provider. And so, whatever we're going to use our operative video for our resident training, I think will be equally, if not even more valuable for training junior faculty members as well. And kind of hopefully decrease this curve so you don't have to have many years of experience or many hundreds of cases before you really get to a very low complication rate and very good outcomes. Um, you know, I think we don't spend enough time as a field talking about how challenging the transition to independent practice is for young surgeons. There's been a couple papers looking both one study from India, one looking at general surgeons, but the risk of burnout is very high for people at the start of their career, and insufficient help is often a big concern for people who are at the beginning of their surgical careers. So I want to just make the claim that what we can use our operative video for our trainees will also be very valuable for our junior faculty members as well. So that's a short little background on the current kind of process of training neurosurgeons and some of the challenges that exist. And I want to just look at, well, like, how good are we at this training path currently? And there's quite a few requirements that are mandated to go through a surgical residency. You have to complete a certain amount of time in a clinical experience. You have to complete certain minimums of cases across a very wide variety of types of cases: cranial cases, vascular cases, spinal cases. You have to take written and oral board examinations. You have to go through competencies and hit milestones at every step along the process to progress from one year to the next. So we have quite a few requirements that are mandated to keep accreditation for any residency program. But I still think there's an opportunity to do better because none of these requirements are actually technical in nature. Looking at your technical ability, they're more of a either fund of knowledge or experiential, but not technical. And there are lots of resources that have emerged to try to improve how residents learn, given the decrease in autonomy that's been documented over the last 20 to 25 years. There are surgical simulators, which we'll talk a little bit about. There are cadaver labs. There's 3D and virtual reality. There's educational videos, which have emerged and I think are very helpful resources. There's conferences and training courses where you can go and get hands-on experience and learn from the experience of others. So lots of different resources are available to help trainees learn. I think simulations and virtual reality play a really key role in trying to prepare for rare events. There's a lot of good evidence in the endovascular world, some of it from Gabriel Zada at USC, kind of training on carotid injuries, which are not common events, and to be prepared for them. This is a quote from Sully about pilots and learning how to deal with rare catastrophic events. And you don't want that first experience to be a real world experience. You want to have simulated practice. And there's lots of opportunities to expand on that in residency education in neurosurgery. But those sort of simulated events and those conferences are not happening on the day-to-day in a residency program. That's not the norm for what you're going to be spending your time doing. Instead, we often have a graduated autonomy of this idea of maybe see one, do one, teach one, where you're learning at the time of patient care delivery. It's really an observership that turns into an apprenticeship that turns into a practice. And this graduated autonomy framework dates back to that time of Halstead that we showed at the first slide. And that was how we've been training people to learn how to do this for over 100 years. But there's a couple problems. As there's been just incredible technological advances, we haven't necessarily changed our educational paradigm to fit the technological advances that are occurring in the operating room. And we've already discussed the well-documented decline in the number of open cases or resident autonomy. And feedback on this day-to-day is often subjective and qualitative, or even just not taking place because people are busy and people often don't have time to sit down and debrief after a case with a trainee to talk about how they did or what they could have done better. There's a lot of bias that gets into this subjective qualitative feedback delivery. And really, you find yourself as a trainee relying on mentorship for your professional development. And it's often very individual and specific to each program who is going to be the most valuable mentors for a learner. And so as a result, the feedback is often limited and very time sensitive. And we often will make very general, myself included, when providing feedback, will make claims about the fund of knowledge or the attitude of the individual, or maybe their ability, but it's not specific and it's not objective. And it's hard to even teach things that you don't have objective metrics to define. So there's a lot of reasons why giving feedback is hard, and I'm not an expert in giving feedback. But one reason is everyone is too busy. And if your calendar looks like this, it's really hard to carve out 20 to 25 minutes to provide good, high quality feedback to trainees. And there's a lot of concerns that constructive feedback will be taken personally and potentially put you at jeopardy um, for punishment if the trainee feels that they're offended by the feedback. And there's been a lot written on the changing generations of medicine from, Generation Y, the millennial generation, to Generation Z. We're also not often trained in the best ways to deliver feedback, and that makes it hard when you're trained to become a provider, a clinician, a surgeon, but you're not trained to become an educator. It's a hard aspect of the job for many people. So what do residents actually want when it comes to feedback? Well, I think residents want formalized feedback that actually can improve their performance. This is a requirement of neurosurgery residency programs that has strong support from the Society of Neurological Surgeons. Often written feedback is desired that provides specific observations about performance and is more constructive than what you get in that subjective quick debrief that may happen at the end of a case. There have been some programs that have tried to build tools to allow for this to take place, where you kind of reduce that activation energy between the more senior surgeon and the trainee to make it easier for this to take place. But I haven't seen that take off across the nation. And I know other programs have been using mobile applications to try to make this real-time feedback more realistic, but there's still, I think, the hurdle of, well, what is the quality of the content of the feedback, even if you're using an app to make it easier to deliver. So although this is a requirement, I think we we haven't done a good job of delivering on that for our trainees. And, I think the field of glioma surgery has evolved far faster than the field of our training approaches and how we teach it, going from sort of maybe limited neuronavigation tools to all of the advanced tools that we have in the operating room now. This demands that we have more advanced training approaches too. And that's, I think, an area that neurosurgery can really build upon in the next 4 or 5 years. So what we set out to do in combination with SDSC is like, how can we actually improve resident education with neurosurgery specific data? And I think we're all kind of used to the idea intuitively that looking at film is a good way to learn and break down performance. Most of us have probably seen a football game where they're breaking down film to explain what happened and why it was successful or not successful. And the people who excel in their own performance fields are well known to be uh, probably the most dedicated individuals in the film room, not just on the court or in the arena or on stage. And this is something that I think we're ready for in neurosurgery, but we haven't really been doing. There's been some publications that are talking about how we can use data-driven approaches to improve residency training, but it's really easier said than done, because right now, if you want to break down your own film, it takes hours to download the film, comb through it, find the areas where there's maybe opportunities to try to go over with an attending. It's not realistic. And when there's more cases to be done, another patient that needs to be seen, it's not a common performance, particularly for junior residents who are often on call and being pulled in multiple directions. And so we're missing a lot of opportunity to do this. And it's not surprising that video performance is able to determine the technical skill of a surgeon. There's been a couple publications that have tried to look at video to predict technical skill, and you can predict fewer complications and lower morbidity rates by looking at the video. So people know it when they see it, but we still don't have those objective metrics to define it. And if you incorporate coaching with operative video, technical skills improve. So this would make a strong argument that if we can create a tool that can allow for trainees to get a summary of their video, maybe a short clip of how they did, and then an opportunity to be coached afterwards by an expert, you could really make a difference in how technical skills develop and how people perform. And the problem is just finding the time to do this. And that's where I think we have maybe a solution. And that's, can we get the game film from the neurosurgery operating room to improve objectivity, timing of feedback, and quality of feedback? And film comes from really two major sources that I'm going to talk about today. I think there's a third source that I don't do a lot of personally, but the operations in neurosurgery will often take place with a microscope or take place with loupes, like eyeglasses with a magnifying lens. You can also have a lot of surgeries that take place with the endoscope. So there's 3 different ways where you can capture video in the operating room. But currently, most of the video goes unrecorded and unanalyzed. And this is where artificial intelligence is going to play a major role. There's been quite a few publications already that have talked about how AI can impact surgical education from creating educational materials, but the majority of them have focused on surgical performance evaluation. I think this is where the field is going. And that can be either from simulations where they actually evaluate your performance doing a task. But I think more realistic is going to be using the video that's being done on an actual patient to provide feedback on the performance. This was a publication that looked at, well, can AI be used to determine who's a novice from an expert? And it turns out they were quite good at predicting who was an expert and who was a novice. Based on the actual labels and the predicted labels, although they're not perfect. So there's still a lot of data that needs to be captured and used to train models to improve these performances. And people have been looking at using AI to provide feedback on performance. And this is just a single paper from Scientific Reports that argues that you can use real-time AI feedback to improve how people are doing more than post hoc feedback, the way that we've been doing it for hundreds of years. And if you actually have experts that can provide feedback with the AI tool, now you can get a synergistic effect to really improve how trainees are doing. And that's where I think we as training programs could really benefit from using this surgical data, is incorporating it with the expert sort of post hoc feedback to provide the synergistic coaching that people really need. And this is just one more graph showing that people do really benefit from this real-time AI instruction, and that there's some synergy with the in-person expert instruction as well. So that leads us to what we've been doing with SDSC, which is trying to identify metrics of technical ability using AI algorithms from intraoperative video recordings. We started collecting a very small pilot amount of surgical video using the operative microscope initially. We used 6 posterior fossa CP angled tumor resections to train a model over 4,000 frames for model training and 1,000 models for testing. And then we wanted to do this in a relatively unbiased way. And so we were defining the distance that tools were moving and if the algorithm could predict certain efficiency scores based on which tools were being used. We also were interested in the focus of the video and where the field of focus was versus where the work was being done to see if that was something that changed with maybe surgeon experience. And so we started out by doing an automatic surgical instrument analytics, looking at the number of times tools were exchanged, how much idle time there was, how much time the retractor was moved. And then we were thinking about, can we expand into other maybe anatomical variables like the cranial nerve visualization or proximity to certain critical structures. These are all very, very specific to each individual procedure, and that makes it more challenging for model development, but definitely an area where I think we'd like to go in the future. And so you end up seeing something kind of like this, where you get a tool in one hand, a tool in the other hand, and a retractor, and the model predicting which is which and how accurate that is. And then you can look at heat maps over time and see how tool detection changes. And this isn't necessarily the most exciting thing, other than to say that you can get pretty accurate with your tool detection over time when you have lots of data to train it on. I'm not going to begin to understand the black box of this and how it works, but trying to create efficiency scores for predicting certain instruments or how often they're changing leads to like timestamps of the retractor, which almost never moves, and the tool, which moves a lot, in 2 different hands. And you can see the right hand doing lots of movement and the left hand not doing as much. And all of these things would make sense if you're watching the video. So kind of a proof of principle that we're detecting what we hope to detect. And then you end up getting lots of different instruments that you want to try to predict. And so that changes based on the surgery that you're looking at, whether it's a pituitary surgery or a retrosigmoid operation. You're going to have to train it on different tools. So I do think these surgical videos need to be clustered into their sort of category for improving feedback, improving accuracy. And I know that the SDSC has done a lot of this with pituitary operations, and that's an area that the algorithms are pretty well kind of validated on currently. We've been trying to make sure that we're getting multiple tools correct when they're all on the same screen, and can we discern what's a PADI, what's a retractor, what's a suction, what's a CUSA, what are the different instruments, and how accurate is it for each instrument, and is it mixing up things like forceps and drills or scissors and drills because they look very similar at their tips. And that's an area where the algorithm has done quite well with a very high level of performance. And similarly, for the field of focus metric, this has been a really interesting and impressive analysis where you can look at the distance from the focus to the center of the screen, how big is the focus area, how much time is the work being done outside of the focus area. And this is where I think we might start to see big variability between junior surgeons and more senior surgeons because the tool changes, for example, you might be able to assign an efficiency metric to that, but where they're working might be even more interesting variable. And what I love about this is it can be done in an unbiased way. We don't have to try to predict what turns out to be the most important if we can start to correlate the video results with the outcome results. And that's where the project is going. So looking at the field of focus over time, one thing that quickly becomes apparent is once you kind of get into the field of focus in the operation, there's really not much that's changing for this retrosigmoid procedure. But as I mentioned, these are going to be very specific to different types of operations. And I think a craniotomy for a glioma resection, we'd see a lot more changes in the focus field and in the time that junior surgeons and senior surgeons spend in focus. So I still think this will be a very interesting thing to track over time. And this is now being reported in different kind of analyses on the SVP pages. And I think this is really where we're going to kind of cut down on that activation energy to view this material and try to get trainees to engage with it, is you can get a summary and a feedback score that gives you an actual metric of how you did and some of the things that you did good versus some of the things that you didn't do quite so good at and how maybe you can improve upon that. You can look at some of the changes over time, and this might help show fatigue, or is there a period when the resident was operating and the attending was operating, and can we actually track a difference over time and how it's generating the scores that it's generating. But what might be the most interesting is you can even use artificial intelligence to generate feedback based on the information and talk about maybe some areas or recommendations to improve, review why there's 25 minutes with no tool time and what is going on. Is that a period where the scope was on, but the surgery was not taking place, or was it a time of indecision amongst the surgeon? And so this all needs to be reviewed and validated for clinical relevancy, but there's tons of potential here, and I think it's going to make a major difference for trainees in the future. And one thing we're hoping to do in the future is actually try to incorporate surgical video into the training program and see if we can actually have residents get feedback and how it evolves over time, see what their learning curve is, and see if there's improvements in performance. And this is something that we're actively working on bringing to our program here. But one thing I wanted to kind of end on, and I'm sorry, one more slide on, I think you can kind of chunk operations into different phases, and in a pituitary operation, it might be the endonasal portion before you get to the sphenoidal portion, before you get to the sellar portion, and all of these might provide good chunks for different trainees at different levels to focus on. Maybe the more junior surgeon needs to focus on the opening portion of the procedure and the closing portion of the procedure, and they're doing less of the critical portions of the procedure. And that brings up this point that I wanted to make, where we had been previously focusing pretty much exclusively on video from the microscope. And while that's really high quality video and very important, a lot of operations don't take place under the microscope. They may take place under loops. And there are cameras that are made that can attach to loops and record video. And we're just now starting to capture video from loops, which hopefully will allow even more junior trainees to provide video that can be used to improve upon performance. And I think this is kind of like an uncaptured wealth of data in the operating room that currently is going to no educational value. So we're really excited about this and are just starting this now. So I wanted to make sure I have enough time for questions. So I think just to conclude, I'll say that I do think we should think about redefining surgical training benchmarks and try to understand how we can improve skills that hopefully improve clinical care. This will be important for engaging and motivating the next generation of trainees. And I think if you have surgical training programs that are getting longer and longer with more and more fellowships, that's not the solution for how we can improve upon our field's performance and get the best people into these fields. I think these tools can also reduce the burden on teachers, and that's important because burnout is a real thing, and being a teacher is stressful at times. And this is a way we can support and augment the feedback we give. And incorporating AI and using surgical video is going to be non-biased. It's going to be more personalized. It's going to be more technical based, and I think that's necessary to do a better job for surgical training in the future. So with that, I'd like to just conclude. I'd like to thank Braxton once again for helping put some of these slides together, and I'd love to have a conversation and answer any questions that people may have.
Great stuff, Dr. Young. Thank you so much for that presentation. That was fascinating. I'll open up to the floor. If there's any questions, please feel free to raise your hand.
Yeah, Andrew.
Andrew.
Hi, Jake. Andrew Porter from SDSC here. Thank you very much. Was wondering a question I tried to ask a few times because we're all kind of still wrapping our heads around this. Wondering what, if any, effect the COVID pandemic had on training in your from your perspective.
Yeah, that's a good question. I think there was, as a trainee during the COVID pandemic, I can give you a little bit of how it felt. In some ways, it didn't change things dramatically in neurosurgery. You know, I think most of the time, the majority of the types of cases outside of a few elective surgeries were still taking place during that period. But the shift to a lot more Zoom learning opportunities, personally, I think it made it a little easier for people to maybe not get as involved or engaged with their education. Like culturally in medicine, I think there was a bit of a shift during COVID where the like kind of everything being in person to everything being virtual, it's been hard to get back to everything being in person. And I don't think it necessarily changed the technical skill development or the case numbers in a meaningful way, but it probably changed your ability to engage with mentors on a very personal and in-person level. I have a question that I'd love to ask like people if they're willing to engage about it. And it's like, I think one of the things that maybe I worry a little bit about with this type of work is the data and protecting the data, and B, having a recording of everything that happens opens you up to potential liability for things that maybe there should or should not be more liability for, but we see this even in the clinical setting when you're talking to a patient. Now there's a lot of AI tools that will record your conversation and help with the documentation. But are you potentially at more risk because there's a recording of everything that you've ever said or done? And I'm wondering if people have any thoughts on that or concerns or not concerns about that.
I'll hop in here because I think this is a question that we have spoken about internally at length. And Andrew, I know perhaps you're probably best placed to answer this, given conversations that have had about whether I can't remember the exact status, was it a patient safety organization?
Yeah, that's right.
There's, and so I wonder perhaps whether you could explore some of that side of things, because I think that's it's a great question from Dr. Young.
Yeah, I mean, this is absolutely something that is top of mind for everyone. Is the double-edged sword of having perfect information about your cases is that you have perfect information about your cases, right? So the there's a legal structure that's been put in place to encourage patient safety related research, which essentially all of this falls under, and it's called becoming a patient safety organization, where essentially if you become a non-discoverable safe space for patient safety work product, viz., all kinds of perioperative information. And the sort of the quid pro quo is that you have to use that data to do some kind of patient safety related research. And so the but as this sort of takes off and gets more and more utilized, that's a luckily a question for which there is a structure. Is that if you can sort of decant this data into a patient safety organization, um, and then that data is used to generate research that helps in some way with patient safety. Um, then you are kind of removing the barrier people feel in a way um, to collecting more of this data, right? Because people are hopefully going to be rational creatures, and they're just say, well, if this, I'm not going to push the record button every time if it's going to be used to, to potentially cause adverse things for myself or my career or my institution. So it's the idea is not to let people off the hook for anything. Far to the contrary, it's to encourage more and more data assets to be created for the purposes of patient safety.
Yeah. Sam, you have your hand up. I think you're off mute, Sam, but we can't hear you. We can
And we
see you,
can
but we
see
still
you.
can't hear you. uh, it's too bad.
Yeah.
See if
Um,
Sam.
Maybe he can throw his question in the chat box, Sam.
yeah. And Neeraj, I've just seen your hand go up.
Yeah, so my question was, I mean, this was a really good and very relevant conversation for what we're doing here at SDSC. My question to you was, how much of, in determining surgical skill, how much do you think the outcomes data is important in determining whether or not the surgical, performance was judged good or bad?
Yeah, I've been talking about that quite a bit, and I think it depends a little bit on which outcomes you're focusing on and how you're reporting the metrics. So when we showed on that slide that the score was like a 47 out of 100,
Right,
but what is that out of 100
exactly.
about, right? And I think you probably want to have multiple scores for multiple different outcomes, because what if you did the most beautiful surgery that anyone had ever seen, but you only took 10% of the tumor out? Is that a
Right,
good outcome, even if you got 100% perfect, beautiful score?
exactly.
And what if you did 100% beautiful score, but it took 12 hours, and someone else had a 90% score, but it
Right,
took 3 hours, right? And so there's probably different metrics that we should focus on. And outcomes in general, meaning like survival, are so multifactorial.
right,
You're probably going to have a very, very hard time finding a
exactly.
serious,
Yeah.
but there are probably things like severe adverse immediate complications
Mm,
that are so rare that you probably will almost never get them in the data set. And that's a
right,
good thing. Like the training has gotten good enough that we're not having
right,
common metrics, that those events
right,
being a common thing. But the 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 outcome, I think, of like time or efficiency, or maybe if you're talking about a tumor, how much was removed, there probably is a way to look at that, and it would probably lead to improvement. Like if you showed someone like, here's how you did, and here's the
yeah,
MRI afterwards, and your score was a 85,
right,
and like next time you did it and it was a 95, you could track people getting better in a
right,
way that is more productive and less
right,
like I think it's probably a long way away from someone using that score to say actually you shouldn't be doing these surgeries because your partner has a 10% better efficiency score than you. So we're as a hospital system gonna make him or her do all the surgeries and you do none of them kind of thing. I don't think we're there yet, but
No. What I wanted to mainly confirm is that there is value in these scores that we give, despite the fact that we don't have like the outcome data, and just want to make sure that a surgeon will find it useful and still, act on it.
I think the question, I mean, proving that it's somewhat useful, like if you can see it improve over time, that
Correct.
feels potentially valuable.
Yes.
Surgeons are, I can't speak for all of us, but most of us are pretty competitive. And so I think if you had a leaderboard, that might lead to some people's feelings get a bit hurt and so
But if it's individual and
but if it's
personal,
individual and and I do think breaking it down and saying like my idle time has dropped by 15%.
right.
Like, and that's like a very easy to capture information. The
Right.
patient outcomes is a little harder to totally envision. So I do think there's value to it.
And then similarly, how much do you think like the actual inherent complexity of every surgery that you do should be taken into account when you're scoring?
I mean, that's hard to
Quantify,
put a
right?
number on in a
Yeah.
quantifiable way because I think it's more about you as an individual against yourself, and your practice is probably going to control for that inherent variability that may
Okay.
take place because the patients that come to our hospital might be different than the patients that go to that hospital. And, you know, that's a hard question to ask. Like, what if the tumor's 5 times bigger? Like, people
Yeah.
might understand that's harder, but how much harder is,
Yeah.
I don't know the answer to that.
Okay. Thanks.
Just saw, Dr. Young, that Sam dropped his comment into the chat. So he said, was just going to say it's probably going to be like body cam footage for LEOs. Initially, a lot of apprehension, but now their use is quite commonplace, as it's probably more likely to be exonerating than incriminating, as long as you're a safe surgeon.
Yeah, I think that's a great analogy and probably true. Like, there's exactly right. It's probably going to be very protective because people don't expect you to be perfect 100% of the time, but they expect you to be safe and acting in the best interest. I think the harder part is when you're training somebody, how do you like pause the recording and put play at a different time because that's the trainee that's operating, and what's the right balance there? And that's a challenge for medicine in general. But I think I like your analogy for body cam footage.
Actually have a question. I'll go first and then over to Rama. I was really struck, Dr. Young, by the see one, do one, teach one piece that you spoke about at the beginning of your presentation. Back when I was in a very different line of work, the saying that we had was explain, demonstrate, imitate, practice. So this was in the army. If you're learning a new skill, which of course can also have sort of quite potentially quite catastrophic outcomes if you do the wrong thing at the wrong time. The idea was that you would, have the instruction, it would be demonstrated to you, you would imitate it in some form, and then you would practice it. And I'm just really curious that how this obviously differs to surgery, where it seems so much, where there are similarly very important skill development to take place, and yet it seems so much more accelerated within surgery. Why do you think that is, like that skill development piece?
Well, obviously it's a bit simplistic to say see one, do one, teach one, because it is like a 7-year training program. And so I wouldn't say that that's happening within a week. That's happening over the course of 7 years. I guess what what I find interesting about surgical training is what is the bar that everyone has to be the best possible person ever before they can go on to do it independently? Or does everyone collectively in the group have to reach a certain threshold that we say is enough to be safe and competent? And the program has been built, and I am not a part of the senior leadership that has designed it, but to do the latter. Everyone at the program needs to reach a threshold of safety and competency. And I think what this can allow is a tool that brings us so everybody is absolutely maximizing their own individual potential from every case that they do. So it's sort of a different structure. Like the goal of current residency programs is to produce safe surgeons. And I feel like the goal of this initiative is to produce the best possible surgeon.
Great stuff. No, thank you. That's helpful. Rama, over to you.
Hi, Jacob Young. Thank you for the presentation. That's great. I just have a question. I know in healthcare, everything advances quite slowly, and I'm sure by now you've maybe even seen it yourself, how some best practices can evolve over time, or maybe you know of other best practices that took, maybe in the 1900s, took maybe 50 years to become a best practice. So my question for you present day is, what do you think would be these needle movers to get this kind of video training or helpful analytics in the hands of more trainees or students or residents? Would it just be one school at a time, or do you know how realistically that may look to you?
Yeah, I mean, I think even at a place with a lot of resources and highly motivated people to improve training and teaching and surgical skills, it's still hard to do because there are so many competing demands on people's time. And even just uploading a video that takes 45 minutes on a computer that doesn't go to sleep during that time and being in one place for that to happen is not always easy. So some of it is like on the compute side. Like if we could get the operative microscopes to connect via cloud to a secure folder that could then be easily accessed by trainees, that would be, and there are, I think, opportunities to do that in some newer microscopes where that's possible. Like that would be a huge decrease in the activation energy to do it. Um, the the type of feedback that I think we all want our residents and our trainees to get, some of that is like cultural. Like I think as we have more people who are a little more connected to the idea of artificial intelligence tools supporting this, there'll be a faster adoption. Um, but it is happening like in front of our eyes. Like we are seeing more artificial intelligence solutions every single day to answering problems. And once people realize that it's going to be the answer to this challenge, I don't think there will be a institutional like hesitancy to use it. So I don't think it's going to be like as slow as maybe things would have been 10 years ago. Because there's just a lot more experience dealing with disruptive technologies in healthcare. I mean, within the last year, I'd say I can't speak for other institutions, but I've seen a just explosion in like AI recording to aid documentation, to aid coding, to aid all sorts of aspects of healthcare. So, um,
Right. So you would say really just making it as easy as possible for everyone to get their hands on everything. It's just as important as the analytics and the videos themselves.
yeah, I think the analytics are obviously key. Like you gotta, but making it like short and digestible. Because if you just did a 12-hour operation and then it takes 45 minutes to get to the place where you need to look at this, and it takes 15 minutes to watch a highlight video, and it takes 4 minutes to comb through heat maps, and then it takes 1 minute to get to like 3 bullet points of what to improve upon, it's asking a lot for people.
Right, right. I really appreciate your answer. Thank you so much for the presentation.
Yeah. Elizabeth, I think I see your hand up.
Yes, hi. I wanted to thank you so much for this presentation. It was really interesting, gave me a lot to think about. I'm a senior data scientist on this end, and well, I guess some of my thoughts are, first of all, about what you're just saying. I think you're absolutely right, and there's some things we can do about each aspect of that to help shorten that time, and then there's some things we can do about trying to really digest the information. But one of the challenges that we've seen on this side is that different surgeons, and especially different surgeons at different places in their career, have different things they might be interested in. And so it's really hard to make it easily digestible, make the data, make the information easily digestible for everyone, because everyone has different ideas of what they want to focus on. I'd love to talk to you more thoroughly sometime offline about even what you think of the metrics that we've developed so far, because those were kind of made by what I came up with those metrics based on what I had in the data. So what I could even measure. And those were the metrics that I could measure. But I think there's other things that surgeons are probably interested in, or maybe they word it differently, even maybe it's the same thing, but they word it differently, or it means more to them. And I think kind of drilling in and understanding those aspects of training and development is one of the things we really can do very, I don't want to say easily, but we can do it. It's possible. I think it was also very interesting to me to talk about the idea of recording everything, and is that dangerous? Because obviously, I mean, to me, I'd love to have everything. I'd love to have the hand movements. I'd love to have the noise in the OR. I'd love to have everything that we don't have, because I think there's a lot of gaps in the information as well from what we can't see just from these videos. And I just thought I know that's not possible, and I know that there's a patient safety and efficacy issues and things like that. But I really wanted to say thank you, because this was a really great presentation with a lot to think about. So thanks.
Yeah, I think one thought to your first comment on like, well, what are the metrics that are being provided? There's probably no perfect set of metrics, but there's almost certainly better metrics for like a PGY1 or 2 trainee versus a PGY7 trainee versus a new junior faculty member. And you can probably almost tailor the feedback to the level of the learner to make it more relevant. And the goal is probably, there is no one perfect way to do a surgery. I mean, I only had the luxury of training at one institution, but I've seen people operate at other institutions, do things very different ways, and have excellent, excellent outcomes. And there are probably, no matter what you used as your training set, you would come up with a slightly different metric for every single person who ever did the procedure based on what you trained it with, right? Like it's so you probably don't need to get all the metrics perfect. Your goal is to provide enough objective information about how someone is doing that they can then use that to improve upon their performance. So I would say it's probably actually better to have different categories that you're providing some feedback on based on the level of the trainee and what they're trying to get to, like how far off are they from the expert level, than the perfect,
Yeah,
instrument
I
training.
agree. And I think there's also something to be said about, even when you're at, or let's say not an expert level, but let's say you're at a higher level, there's something to be said about you probably still, it's helpful to have goals, right? And if you have a goal and we can help you measure that goal and help you measure your progress to that goal, I think that's something we can provide, but the goals are going to be different for different surgeons and for different people and for different procedures and things like that. So I think that's very interesting and something we're definitely looking at.
Yeah. And as far as the other things going on, I mean, I think that is very relevant. Like maybe some of the downtime in the video is because there was an urgent patient matter that had to be addressed for 10 or 15 minutes that led to like a short delay in the next step of the case. Like that's just real life. And so you wouldn't have that information from the video alone. But that's why it's good to look at those time series and try to maybe find patterns that emerge over multiple cases and that sort of thing. And having some clinical correlates are helpful. Like, was there a major event happening with the patient that required anesthesia to do something and us to pause, and that's why there is a delay? You'll never know based on the video alone.
Okay,
But
Dr. Young,
that's
I've just
oh sorry.
I've just
Oh no,
taken a
but
quick look at the time, and it's 3:04 p.m. And so I think what we'll do now is pause the recording, say goodbye to some of our externals who are on the call, and take the conversation just to an SDSC audience. So